Today our topic of discussion is short stature, right? Last class we have learned about what? Failure to thrive. Right? Failure to thrive, that is abnormality in the weight, low weight. Today we will discuss about the abnormality in the height, that is short height. That is called short stature. Let's look at the definition. What is short stature? Whenever the height of the child is less than 3rd percentile in the growth curve, in the growth chart, or it is below 2 standard deviation below, more than 2 standard deviation below the median of the height for a particular age and gender in a given population, right? So, this is short stature. This is the definition of short stature. In any given population, it has been seen about 2 to 3% of the child they present with the short stature. Okay. Now let's look at the etiology. It can be etiology, maybe physiological or pathological. Now all of you know what is normal distribution curve. You have done with the comet, na? You have done with comet though. The normal distribution curve, you know what is normal distribution curve? It is a bell-shaped curve. In the middle point there, the median is indicated by 0. Below that, above that, 1 standard plus 1, 2, plus 2, plus 3, 1 standard deviation, and below that, minus 1 standard deviation, minus 2 standard, minus 3 standard. So, below this minus 2 standard deviation, we called it as short stature. Now, those childs who presents with height less than minus 3rd standard deviation, they suffer more from pathological causes. And those whose height varies from between minus 2 to minus 3, they have been found to suffer from physiological causes. Okay. Now, what are the physiological causes? Look, it may be familial or constitutional. In the later part, we will discuss thoroughly about these two features. Okay. Now, let's move on with the pathological causes. In our country, the most common pathological cause is undernutrition. Remember, it is not malnutrition, it is undernutrition. So, it is not the malnutrition, because under malnutrition what comes? Obesity also comes. So, this is not the cause. So, you have to mention it is as undernutrition. This is the most common cause. Apart from undernutrition, the next common cause is chronic illness. Any chronic systemic illness that causes short stature. Why? Because even if those patients, those child, even if they take the proper nutrition, proper food, but most of the calories, most of the energy are getting exhausted for the disease purpose. Okay. So, they suffer from short stature also. What can be the chronic illnesses? Starting from the CNS, it may be cerebral palsy. In the lungs, any chronic lung disease like cystic fibrosis, asthma. Regarding the heart, any congenital heart disease, cyanotic, acyanotic. Coming down to GI system, malabsorption. The child is taking the food, but it is not getting absorbed. So, malabsorption, like celiac disease. Okay. Other than this, chronic liver disease, CLD, acquired immunodeficiency syndrome. In acquired immunodeficiency syndrome, they present with so many features, but most common is a malabsorption, and they also presents with short stature also. Okay. Other chronic disease like chronic kidney disease, chronic renal failure, these are also included under chronic illness. Next common cause is the endocrine cause. There are several factors under endocrine causes. The most common is the growth hormone deficiency, followed by which? Hypothyroidism. Growth hormone may be deficient or insensitive. Insensitive means not functioning properly. Okay. What are the other causes? Endocrine causes, Cushing syndrome. Cushing syndrome is what? It is associated with which drug? Steroid. prolonged exposure to steroid, prolonged exposure to cortisol, okay. This causes Cushing syndrome. You go to home and look at the, take your pharmacology book and today only, okay, get the features of Cushing syndrome. One of the important feature is growth retardation, okay. Other causes pseudo-hypoparathyroidism, precocious puberty or delayed puberty. Next is the bony defect. Bony defect is found in what? Rickets. Skeletal dysplasia. What is skeletal dysplasia? This is also a bony defect. What happens in skeletal dysplasia? There is a inborn error of formation of cartilage or bone. So, bone is abnormally, there is abnormal growth in the bone. The bone is not growing properly, which ultimately causes short stature. Okay. Next important is as SGA, that is small for gestational age. When we will call it as small for gestational age, if the birth weight is less than 10th percentile according to the gestation, then we will call it as small for gestation. Why there is small for gestation age? There may be some insult at the level of maternal placenta or in the fetus, which causes the fetal growth retardation. Fetal growth retardation, and ultimately the baby is born with the small for gestational age. Now it has been seen among those children, among those babies, they attain a catch-up growth. You know what is catch-up growth? Is it that the term is known to you? The catch-up growth is what? If you follow up these babies till 2 years, you will see that the weight for age and the height for age is below the percentile, below the third percentile. But after 2 years, they are gaining the normal weight for age and the height for age. This is called catch-up growth. So, most of the SGA babies, they attain the catch-up growth by 2 years, but among them, there are also exceptions, 10 to 15% they fails to attain this catch-up growth. So, they remain short throughout their life. Okay. Another important thing is the psychosocial dwarfism. What is psychosocial dwarfism? They basically the babies who come from the broken family or the unhappy family. There is emotional deprivation, okay. Emotional deprivation causes what? Their brain is not growing properly. The growth of the brain is hampering. So, ultimately what happens? There is functional hypopituitarism. From the pituitary gland, the growth hormone secretes, okay. So, there is functional hypopituitarism, which results growth retardation, okay. In this case, even if you give the growth hormone as a treatment, you will not get any proper response. But if you put the child in a stress-less environment, if you provide with the emotional support, proper love and affection, you will get a good response, okay. So, this is called psychosocial dwarfism. There are also genetic syndromes like Turner syndrome, Down syndrome, Prader-Willi. Short stature is a very common features of these genetic syndromes. And lastly, 30 to 40%, in 30 to 40% cases, no cause or no etiologies have been found. So, in those cases, we call it as idiopathic short stature. So, these are all about the etiologies. You have to keep in mind about all the factors. Then only you can go for the further evaluation, right? Any query from this point till up to this, any query is there? Okay, next move forward. So, assessment. Now, assessment. A child has come to you in your clinic with his or her parents or mother. The mother is complaining about the poor growth, okay. What you will do? You check the height yourself, okay. You check the height yourself whether it is actually short stature present or not, okay. Now, how will you assess the height? এটা তো সবারই জানা. How will you assess the height? Less than 2 years. মনে পড়ছে ছবিটা? What is this? Infantometer. Infantometer used for less than 2 years of age. লেন্থ নেওয়া হয়, এটা হচ্ছে লেন্থ। লেস দ্যান 2 years এ লেন্থ নেওয়া হয়, বিকজ দ্য বেবি ক্যান নট স্ট্যান্ড প্রপারলি। আফটার 2 years স্টেডিওমিটার। তো বল এতক্ষণ চুপচাপ কেন আছিস, মুখ খুলতে হবে তো। নেক্সট ইজ আ স্টেডিওমিটার, ঠিক আছে। So you have done with the, you have measured the height or the length, and next you put it in the growth chart. Growth chart specific for girls and boys. Girls এর growth chart এর কি কালার হয়? Pink. Boys এর blue. আলাদা কিছু জানেন না। আচ্ছা, so it is done. Now you have put it on the growth chart and you have found the way height is coming as less than 3rd percentile. So it is short stature. What you will do next? What you will do next? Next you have to look for height velocity. এই ওর পিছনে, concentrate in the class. এদিকে চলে আয়, এদিকে চলে আয়। You have to discuss না, otherwise there will be no fruitful result. সামনে চলে আয়। What is height velocity? Height velocity is the rate of increase of height over a particular time period. It is expressed in the unit centimeter per year. Okay, centimeter per year. Now this height velocity is very high in the first few years of life. In the first year it is about 25 centimeter per year. Then there is a decline to 4 to 6 centimeter per year in the pre-pubertal time. The baby is growing but the rate is getting decreased. But there is a height spurt in the puberty. You will get growth spurt বা height spurt যেটা আমরা বলি, 8 to 12 centimeter per year. Why it is important? Suppose in your clinic mother has come to her child, suppose take 4 years of age, okay, and the mother is complaining that my baby's height was the growth was good in the first few years, but for the last 2 years the height is not that much. Doctor, please help me. What you will do? You first assess the height. Suppose you have got the height above 3rd percentile, so it is not at all short stature. Then you assess the height velocity. Now for height velocity you must get another measurement. If any measurement is known to mother, get the information from her and look at the height velocity. If the height velocity is normal, then reassure the mother there is no problem. The height rate is like this only. You don't have to worry. Okay. So this is the height velocity. But if the height velocity is less than this range, you have to be concerned about that. So next measurement is the genetic potential. What is the genetic potential of the height? The genetic potential is actually the ability of the child or the extent up to which the child can gain his adult height. Adult height কতটা হতে পারে সেইটা তার একটা measurement. For that, what is a parameter? Parameter is a mean parental height. Both parents' height must be known to you. Both parents' height. Mother's height plus father's height in centimeter divided by 2. Add 6.5 for boys. If the baby is boy, add 6.5 to this and subtract 6.5 to this in case of girls. The value you have got, put it in the growth chart in the 18 years of age. Put it in the 18 years of age. Plus 6 centimeter and minus 6 centimeter. This is the normal range in which the child will attain his or her height when he will be 18 years of age. Is the concept clear to everyone? Clear though? If anyone, if the concept is not clear, please ask me. It is clear? Okay, so this is the genetic potential. Next assessment is the body proportion. This is also known to you, right? Upper segment, lower segment. How to get upper segment? Height টাই জানানো নেই, এবার upper segment মনে আছে upper segment কি করে নিতে হয়? upper segment head circumference করতে পেলো। upper segment হচ্ছে the height উপর থেকে till symphysis pubis, this is the upper segment, and below symphysis pubis is the lower segment. If you can get it by two ways. In the height is mentioned about, ask the child to sit on a tool against the stadiometer, get the height, then get the height of the tool only, then subtract it, you will get the upper segment. For lower segment, you can get another procedure. Ask the child to be in supine position, take a measuring tape, take the length from the symphysis pubis to medial malleolus. You will get the lower segment and subtract it from the height, you will get the upper segment. Anyway, okay. So, upper segment is to lower segment. The normal ratio is what? At birth, it is around 1.7. So, upper segment is 1.7 times more than lower segment. At by 3 years it is 1.3, by 6 years it is 1.1, by 10 years it is 1, and in the adult it is 0.9 centimeter. Basically adult der kshetre ki upper segment is slightly lower than the lower segment. Okay. If this ratio is abnormal means what? It can be more than the normal ratio or less than the normal ratio. More than the normal ratio means what? So the upper segment is longer or the lower segment is shorter. What we give, where we will get it? In the disproportionate case, skeletal dysplasia, where the long bone growth is defected. Marfan syndrome, achondroplasia. Okay, in those cases, US is to LS ratio will be hampered. It will be low, and where it will be high, it will be high. Where it will be low? When the vertebral growth is affected. In that case, the ratio will be less than the normal. Okay, so this is about the proportion of the body proportion. Next, SMR, sexual maturity rating. Few points, only we for this class we have to know about few points, other it will be taught in details in the endocrine class. Just remember, it is done only above 7 years of age, okay. It is only above 7 years of age. Height spurt or the growth spurt is early in case of girls. Look at this graph. For girls, the height spurt, this is the height spurt in around 10 to 11 years. Look at this graph carefully. But in the boys, it is around 13 to 14 years, age in years 13 to 14 years, mid-puberty. The height spurt is in the mid-puberty for the boys and early puberty for the girls. Another, just one point, what is precocious puberty? What is precocious puberty? The puberty is attained much earlier, okay. What happens in that? There is premature epiphyseal fusion. Premature epiphyseal fusion that ultimately resists the growth of the metaphysis. That ultimately results in short stature. Okay. Bangla ekta kotha ache, there is a word in the Bengali, okal pokko. It is just like that. Okay. So only these few points. So we have done with the assessment. Now detailed evaluation. We know the causes, we have known about the causes, we know how to assess. Now next move forward. Start with the history. History, when we will get, that is the child has come to you with short stature. You have seen that it is actually short stature. You have done all the required anthropometric measurement and there is abnormality. So proceed with the further evaluation. Start with history taking. History should be taken not only from birth, much earlier than that. Why? Seta to lekha ache. Because we have seen that there is a cause called SGA. SGA is one of the important cause of short stature. So start with that. Whether there was any antenatal infection like torch infection. PIH is what? Pregnancy induced hypertension, which causes placental insufficiency. Okay, placental insufficiency that ultimately hampers the fetal growth. So go for the antenatal, all the antenatal growth centile if available from the USGs, antenatal USGs. Get information about the birth weight, length, head circumference and all prior information regarding the growth monitoring. Whether if any prior growth monitoring done to the child, get all the informations. Because you have to know about the height, velocity, any prior history. Another important thing is the nutritional history. From your clinical classes, all of you should know how to take nutritional history, right? জানা আছে তো সবার নিউট্রিশনাল হিস্ট্রি কিভাবে নিতে হয়? প্র্যাকটিক্যাল ক্লাস যেগুলো করিস কি নেওয়া হয় নিউট্রিশনাল হিস্ট্রিতে? ক্যালোরি ডেফিসিয়েন্সি, এনি ক্যালোরি ডেফিসিট রয়েছে কি না রয়েছে, or protein deficit if present or not, we get the information about that. It is very important because the most common causes are undernutrition. So you have to take about the nutritional history. Other also take the development because nutrition affect the developmental history or anything else, any history regarding any chronic illness, whether the child suffers from recurrent cough cold, recurrent pneumonia, whether there is presence of any antenatal history of birth asphyxia, premature birth. Look, weeks of gestation. Why it is important? Premature birth, premature baby suffers from cerebral palsy. So in those cases, height will be hampered. Okay. So for this case, we have to take all the possible histories. Look at this. This is a picture is taken from high only. There is the possible symptoms and clues against it. If the low birth weight, it may be small for gestational age. Polyuria found in CKD, in the early stage of CKD, obviously, not in the late stage. Chronic diarrhea, greasy stool for malabsorption. What kind of malabsorption? Greasy stool? Fat or malabsorption. That causes fat is not getting absorbed properly. It is coming out with the stool and makes the stool greasy. Okay. Next is a neonatal history of neonatal hypoglycemia, prolonged jaundice, micropenis. All these things indicating towards congenital hypopituitarism. Congenital hypopituitarism. Headache, vomiting, visual problem, any space occupying lesion in the hypothalamus like craniopharyngioma. Any other acquired cause? Suppose the child suffered from cranial irradiation or tubule, any meningitis happened, there was any insult which causes acquired hypopituitarism. What are the features of a hypothyroid? There will be lethargy, constipation, poor weight gain. Now, a nutritional history, you have also taken social history important to exclude psychosocial dwarfism. Delayed puberty. Delayed puberty will be present in the parent. Delayed puberty in the parent, it will be present in the constitutional delay. We will discuss later in detail. Now done with the history, let's go for examination. We have done the anthropometry properly, but at the same time you have to look for other things also. We have to done detailed systemic examination and detailed head to toe examination. What you will get in a head to toe examination? Any dysmorphism. Look at the faces. Any dysmorphism present, that will be present in the any genetic cause. Any vitamin deficiency. From the undernutrition, there will be features of vitamin deficiency. It has also been taught in the nutritional class, right? At the same time, chronic, every system you have to examine. Take your stethoscope, auscultate the chest properly, auscultate the heart properly. Not only auscultation, you have to do all the things, palpation, percussion, all auscultation. Get the examination of the abdomen. Kidney will be, sometimes it will be palpable. You can get some PCOS, PCKD. Okay, in those cases, it is a chronic kidney disease. You can palpate the kidney. So thorough examination and obviously CNS examination. Any hypertonia, any contracture that are present in cerebral palsy. So every detailed systemic examination you have to do. Disproportion is found in what? Skeletal dysplasia, dysmorphism, congenital syndrome. Any one of you can tell me what is the faces of Down syndrome baby? Mongoloid, moon faces actually it's the features of Cushing syndrome, Cushingoid faces. Mongoloid faces, mean there is upward slanting of the eyes, আর কি হবে? কানে কি হয়? কান? Low set ears. Low set ears are depressed nasal bridge. Depressed nasal bridge. This is the faces of another thing, single palmar crease, Down syndrome. Okay, single palmar crease. ওই তো palmar crease, single palmar crease. একটা straight হবে, straight. তো single palmar crease তো বলে। Simian crease, simian crease, simian crease. Turner syndrome কি হয় বলতে পারবে কেউ? There is an anteverted triangular faces with waved shaped neck, There is also depressed nasal bridge, low set ears. So these are the dysmorphism is very important for short stature. Pallor, in any chronic illness you will get pallor, and obviously in the chronic kidney disease also, right? Hypertension is a features of chronic kidney disease. Look for frontal bossing, depressed nasal bridge. These are the features of hypopituitarism. Previously it was regarding the symptoms, this is regarding the signs. In the hypothyroid you can get goiter. What is goiter? Enlargement of thyroid gland, that is goiter. Coarse faces হবে, দেখ central obesity stria, এগুলো হচ্ছে Cushing syndrome, মনে পড়ছে Cushing syndrome টা এবার? আচ্ছা, নেক্সট হচ্ছে BMI TMI তো আমরা দেখেছি, rickettic changes. What is rickettic changes? পড়ানো হয়েছে তো ভিটামিন সি ডেফিসিয়েন্সিতে, হ্যাঁ ভিটামিন ডি তে, হ্যাঁ কি বলছিস? র্যাকেটিক রোজারি হয়, আর এখানে কি হয়? হ্যাঁ সেগুলো হতে পারে, সেগুলো কেসে হ্যারিসন সালকাস মনে আছে? হ্যারিসন সালকাস। So this is the all these features we have to keep in mind and look for that. So these are all about the examination. In case of so this for the in evaluation part we have already done with this. This is also done. Next step is the bone age. Very important concept. Make your concept clear regarding bone age, height age and chronological age. What is bone age? Bone age, it is basically the skeletal maturity. The skeletal maturity. What we can get, how to get the bone age? For bone age, we have to do X-ray. X-ray, usually it is done of the X-ray hand and wrist of the non-dominant hand. Okay, non-dominant hand. Other also you can get the X-ray of elbow, knee. What happens? There is this appearance of epiphyseal center is fixed for a particular age, and also the fusion of epiphysis with the metaphysis. This is normally fixed for a particular age. We have to look for that. Okay, we have to look for that whether it is normal for this age of your child, whether it is normal or less or more than that. What is the skeletal maturity of the child? That is we can get from the bone age. What is height age? Height age is what? It is the height of the child. Well, suppose your the child has come with a 96 centimeter is the height. Okay, now you look for that 96 centimeter is a 50th percentile for which age, right? This is your height age. Skeletal maturity is a bone age. Height age we have got from the height of the child is 50th percentile for which age, that is the height age, and chronological age is according to the date of birth. Okay, a concept clear আছে? তিনটা concept পিছন দিকে সবার, if any query you can ask me. Bone age, height age, chronological age. So you have found actually bone age is done from the, it is compared with the atlas. Bone atlas এর সাথে compare করে দেখা হয় whether it is normal for this baby or abnormal. Now how to compare all these things. In a normal cases, height age will be is equal to chronological age as well as bone age. All these three things will be equal. In case of constitutional delay, there will be bone age, chronological age is higher than both bone age as well as the height age. But in familial short stature, what happens? Bone age is equal to chronological age and both of them are higher than height age. When we will discuss these 2 points, the concept will be much more clear. Okay. In precocious puberty, okal pokko, that bone age is more than chronological age because epiphyseal fusion done prematurely. বাচ্চা তখন সেই এজে পৌঁছায়নি যে তার আগে প্রিমেচুর এপিফিউশন ডান হয়ে গেছে তো but the final height we have found it is delayed. So bone age will be higher than the chronological age, higher than the height age. বোঝা গেছে? Precocious puberty তে কি হয়? Other endocrine cause bone age is less. Bone age less than height age, less than chronological age. Any problem is there to understand? Please feel free to ask me. বোঝা যাচ্ছে? সবার ক্ষেত্রে বোঝা যাচ্ছে? লাস্ট আমি কোয়েশ্চেন ধরবো কিন্তু। Next is the evaluation, investigations. So from the history and clinical examination, we have got some provisional diagnosis. Now we have to do some investigations for confirmation. Okay. In the level 1 investigation, not all the investigation at the same time. We have seen that most common causes are undernutrition. Undernutrition is alada kore kono investigation darkar hoy na, but the next common cause is what? Chronic illness. So first investigation is done for any chronic illness. Look at this CBC, complete hemogram with ESR. Okay, complete it will be altered in any chronic illness. Bone age we have done already, X-ray we have done. Urine analysis, any kidney problem is there. Blood urea creatinine. Stool examination for malabsorption. Stool REME kora hoy. Okay. Next is a bicarbonate pH, calcium phosphate, alkaline phosphatase. It is for what? Rickets. LFT, sugar. So these are the basic investigation. If you have got any problem in that, treat with it, but if the first level 1 investigation comes as within normal limits, then go for the level 2 investigation. Under level 2 investigation, what we do? Thyroid test we do. Okay, thyroid test we do karyotyping. Other is if there is a suspicion of any malabsorption, celiac serology. Do you know about celiac serology? Janish? Ki antibody hai? Anti-gliadin antibody. আচ্ছা আর হ্যাঁ অ্যান্টিবডি গুলো কি সেরোলজি মানে আমাকে অ্যান্টিবডি করতে হবে টিটিজি এন্ডোমাইসিয়াল অ্যান্টিবডি ডিজিপি অ্যান্টিবডি ওকে এগুলো করা হয় দেন সো ইফ देयर इज एनी প্রবলেম ক্যারিওটাইপিং করা হচ্ছে and treat accordingly but there is no problem. Then you will go for the level 3 investigation. We have to do growth hormone assessment. How to do the growth hormone assessment? Provocative growth hormone testing. Or the first do the insulin-like growth factor. Growth hormone, এটার আগে যেটা করা হচ্ছে insulin-like growth factor assess করা হয় blood এ. Okay? আর এটা হচ্ছে insulin-like growth factor binding protein. Provocative growth hormone testing এ কি করা হয়? We provide some agent from the outside and see the secretion of potential of the pituitary gland to secrete the growth hormone. Okay, we do a prior blood test and we compare do the after blood test and compare that between two results whether the growth hormone level is increasing or not. If it is increasing, there must be some stimulatory defect, so you have to give the stimulation. But if even after giving the secretagogue, the growth hormone level is very low, then there is problem in the there is deficiency. You have to provide growth hormone from the external source. Why there is deficiency? For that, look for the pituitary gland. What is the problem in the pituitary gland and hypothalamus? Do MRI brain. So, at very first visit, you will not go for MRI brain. You will not go for MRI brain. First do the basic investigation. If there is any problem, treat that. If these first level investigations are normal, go for the second one. If the second line is normal, then go for the third one. Okay. So, this is about investigations. Skeletal survey. Skeletal survey is done in what? When there is bony abnormality we are suspecting, like skeletal dysplasia. What we do when there is disproportionate short stature, we get the history, whether there was any family history present or not. We thoroughly examine the limbs, what abnormality is present over there. X-ray series of X-rays are done. In skeletal dysplasia, there are so much abnormality. For that, we have to do all these X-rays in a suspected case. X-ray skull, what we found in skull vault is large, but the skull base is very short. In the thoracolumbar spine, there is chance of kyphoscoliosis. Okay, there is chance of kyphoscoliosis. Chest, rib, flaring of the ribs, shortening of the ribs. Pelvis, what happens? The cavity is the pelvis is broad, but the cavity is very short. Okay, so this features is found in case of skeletal dysplasia in the pelvis abnormality. Other bone abnormality, you have to look for that bone growth. For all these things, these are all X-rays should be done. Okay. Now coming to the familial short stature and constitutional growth delay. Make your concept clear. All these two are the physiological etiology of the short stature. What happens in familial short stature? There is the genetic potential is low. Okay, the baby's height has been found to be less than 3rd percentile, but that is normal for this baby. It is normal for this baby. In this case, you will get the mid-parenteral height, and you will put it in the, if you put it in the growth chart, in the 18 years of age, you will get that it is coming below the 3rd percentile. Okay, so there will be normal growth velocity. There will be normal growth velocity. Birth weight is normal. But then there is a catch down growth in the 2 years. When you will follow up this case, you will get then in 2 years the height is coming down below the 3rd percentile, and it remains below the 3rd percentile throughout the childhood, throughout the adolescence, and throughout the adulthood. Their puberty will be normal, body proportion will be normal, because there is no other abnormality, only the height is less. আমরা বলি না বাবা মা বেটে তাই বাচ্চা বেটে. It is just like that. This is the familial short stature. In that case, bone age will be normal to chronological age. No other treatment, only reassurance and annual growth monitoring. Annual বছরে একবার একটু anthropometry গুলো দেখে নিলেই হবে. Look at this is a chart, growth curve. It is showing that the height is constantly below the 3rd percentile. It is constantly below the 3rd percentile. Now, when you will compare this with the constitutional delay, what happens in constitutional delay? The baby is, the height is below the 3rd percentile for a time period, for a particular time period. In their birth weight is normal, and there is, for the 1 year, the birth weight, the weight is improving normally. The baby will gain the weight normally, but after 1 year, there will be fall in the height and weight below 3rd percentile. At that you will understand, at the age of 3 years, the height is below the 3rd percentile, and for the rest of the childhood, it will remain below the 3rd percentile. their height velocity will be normal. Their height velocity is normal except in the puberty, because their puberty will be delayed. Delayed puberty will be there, which causes delayed height spurt or delayed growth spurt. But delayed growth spurt will cause what? Even if there is delayed growth spurt, the final height will be normal. The final height will be normal. In familial, what was happening over there? The final height is expected to be persisting below the 3rd percentile. But in constitutional delay, final height will be normal. Only there will be delayed puberty, there will be history of delayed puberty in the parents also. There is also no treatment is required, only reassure. In that case, your counseling should be quite difficult, because in that cases parent height is normal. Parent height is normal. Okay, parent height is normal, so you have to counsel the parent very carefully. You have to counsel the parent very carefully. This familial and constitutional growth delay, the baby should be under follow-up. It is not for a single visit treatment. It is not for a single visit management. The management should include a thorough follow-up. Thorough follow-up, annual monitoring of the growth, and reassure the parent. Okay. Concept is clear about familial short stature and constitutional growth delay. These are the physiological factors, physiological causes. Look at the graph. There is, see, the birth weight is normal, but then it is going towards the right. Okay, it is coming down below the 3rd percentile. It is persisting below the 3rd percentile, but in the 18 years of age, growth spurt is delayed. Final height is, look, 75th percentile, 50th percentile. Right? বোঝা গেছে এই জায়গাটা? আগেরটা কি হচ্ছিল? It is persisting. The final height is below 3rd percentile. But here the final height is 50th percentile. ঠিক আছে? Now management. In management, when we know the etiology, when we have the diagnosis in our hand, we have the causative factor in our hand, there is nothing to worry about treatment. Okay, counseling. I have told about counseling in case of physiological causes. You have to do very carefully. This is a very important part. Dietary advice. Dietary rehabilitation should be given. Dietary rehabilitation should be given in case of undernourished child. Positive emotional environment. At the same time, শুধু খাবার দিলে তো হবে না, তার love, affection, all these things should be provided. If any chronic illness is there, treat it accordingly. Okay. Physiological cases বললাম reassurance করা ছাড়া কিছু করার নেই. Skeletal dysplasia তো বেশি কিছু করার নেই, nothing to do much with the skeletal dysplasia. What we can do, not we, orthopedicians, they can go for a limb length of OT, okay, a corrective OT, corrective measurement. If there is hypothyroidism, what to do? Provide thyroid external, from the external source, levothyroxine. Growth hormone. Growth hormone should be given in case of not only for growth hormone deficiency, but also this is very useful, for also for Turner syndrome, SGA baby with inadequate catch-up growth, and CKD. But in with respect to growth hormone deficiency, in last 3 cases, the dose requirement is higher, quite higher than the usual one. So this is about the growth hormone treatment. Lastly, growth monitoring tools. Growth chart to amra shobai jani. Nowadays in our Android phone, we have in all the pediatricians Android phone, there is a IAP growth chart app is available. Okay. Another thing is WHO Anthropla software. Just these are only for your informations. These are only for informations. Referral criteria. When to refer, whom to refer. When the case is beyond our hand. When the treatment, we are not getting the proper response even after treating the baby adequately, or in case of hormonal problem like hypothyroidism, you go give thyroid, levothyroxine or growth hormone, but at the same time, especially in case of growth hormone deficiency, also consult with a endocrinologist. Skeletal dysplasia এর জন্য ওকে কোথায় পাঠাতে হবে? Refer the child to orthopedician. Ultimate treatment এর জন্য। Growth failure হচ্ছে dietitian এর help নিতে হবে। So this is about the only the referral criteria. So this is about the short stature. কি ধরনের question আসতে পারে তোদের? Short stature উপর short note. Write a short note on short stature. All the point you have to mention. What is the definition? What are the causative factor? Okay. How will you approach? How will you approach? Approach টা খুব ভালো করে লিখতে হবে। So ওই ঘাইয়ে প্রত্যেকটা চার্ট যেগুলো আছে ভালো করে পড়বি ওগুলো। আর যেটা তোর আসতে পারে ফ্যামিলিয়াল শর্ট স্টেচার আর কনস্টিটিউশনাল গ্রোথ ডিলে, এইগুলো আলাদা আলাদা করে শর্ট নোট আসতে পারে। আর দুটোর কম্পারিজন, ভেরি ইম্পর্টেন্ট কোয়েশ্চেন, the comparison between the familial short stature and constitutional growth delay. Okay. Lastly, few MCQ questions. First question, puberty delay in constitutional growth delay, true or false? কেন? Constitutional growth delay তে কি বললাম? ওটা না, ওটা কি হলো? আচ্ছা, anyone else? Puberty will be what? True. দেখ ভালো করে দেখ এই জায়গাটা। Puberty ঠিক হয়নি, puberty কোথায় হচ্ছে? 13 থেকে 14 বছর বয়সে। দেখ delayed growth spurt, এটার অ্যাডাল্ট হাইটটা নরমাল হলো, অ্যাডাল্ট হাইটটা নরমাল হলো, কি বললাম? ডিলেড গ্রোথ স্পার্ট। দেখ puberty is delayed, সেই জন্যই তো আমার bone age is equal to height age which is coming less than the chronological age. ফ্যামিলিয়াল শর্ট স্টেচারে তোর, এই ফ্যামিলিয়াল শর্ট স্টেচারে তোর হচ্ছে পিউবার্টি নরমাল, সেখানে সবই নরমাল, খালি ওর হাইটটা ছোট। তো অত চিন্তা করো না, মাকে বলবে তোমার ওর হাইটের দিকে অত নজর দিয়ে লাভ নেই, এমফাসাইজ অন দ্য আদার পজিটিভ অ্যাসপেক্ট। অনেক সময় কি হয় না, only reassurance means what? Just to say it is okay. Is this enough for a parents? No, this is not enough for a parent. You make them understand and ask them to emphasize on the child's positive aspect. ভালো গুণগুলো নিয়ে নারিশ করতে বলো, শুধু হাইট নিয়ে পড়ে থাকলে হবে না, এইভাবে বোঝাতে হবে। ওকে, ঠিক আছে, তাহলে বোঝা যায় কনস্টিটিউশনাল ডিলে আর ফ্যামিলিয়াল শর্ট স্টেচারের মধ্যে ডিফারেন্সটা। আচ্ছা, নেম ওয়ান কজ অফ ডিসপ্রপোর্শনেট শর্ট স্টেচার। অ্যাকন্ড্রোপ্লাসিয়া। তুই তখন বললি মারফান সিনড্রোম, মারফান সিনড্রোমে আমরা এটার মধ্যে আনতে পারবো না, কেন? মারফান সিনড্রোমে কি হয়? তো টল স্টেচার, টল স্টেচার ওটা অ্যাবনর্মাল, বাট দ্যাট ইজ নট দ্য ডিসকাশন অফ টুডেস টপিক, দ্যাট ইজ টল স্টেচারের আলাদা ডিসকাশন, দ্যাট ইজ নট, ইট উইল নট কাম আন্ডার শর্ট স্টেচার। আন্ডার শর্ট স্টেচার ইট ইজ অ্যাকন্ড্রোপ্লাসিয়া। ভেরি গুড। লাস্টেরটা তো এটা সবাই পারবে, ইনফ্যান্টম। এটা তাহলে আগের দিনের ক্লাসগুলো পড়া হচ্ছে না ঠিক মতো, তাই তো? একজন দুজন ছাড়া কেউই পড়াশোনা করছে না। Any query? Any questions? I have talked a lot.